Great. Thank you. Thank you. So thank you very much for all of you for staying on this beautiful Saturday. Decades ago, heart disease in women wouldn't even be on a conference schedule, and a true fact is that an American Heart meeting decades ago actually had how to help your husband cope with heart disease. But we've learned a lot about heart disease in women, and it's a lot to cover in an hour, so I'm going to kind of float from topic to topic and deal with things such as coronary dissection, microvascular ischemia, and then talk about pregnancy, which is my special interest. So cardiovascular disease is the leading cause of death in American women, more than all cancers combined, even breast cancer. We have recent data that was published in the Journal of the American College of Cardiology this summer that said that still 45% of women are unaware that heart disease is their #1 health risk. And the awareness is even worse in ethnic minorities, only 77%. So 77% of Hispanics have no idea that this is their #1 health risk. Only 39% of primary care physicians felt that cardiovascular disease was their top health concern. Higher than that was obesity and breast health. And only 42% of cardiologists felt that they were extremely well prepared to assess cardiovascular disease in women. And this, again, to show the statistics, is that men in blue, women in red, about 400,000 women die of heart disease every year, which is more than men that die of heart disease. The next most common cause of death in women is cancer, which includes breast cancer. And not to say that breast cancer is not an important women's health issue, but the National Cancer Society has done a really good job of making women aware, and I think the American Heart Association is working on that and hopefully improving awareness. Fortunately, with all the new medical technologies and medicines and diagnostic tests, mortality has fallen with women in red and men in blue. But you can see that the mortality reduction in men is actually lagged behind that of men, and there's actually a slight uptick in mortality in younger women, so women less than 50. So why do we need to approach women differently? One is that this lack of awareness. Number two is women present with atypical symptoms. So the classic textbook of pressure in your chest, to your arm, and your neck and your arm can happen in women, particularly postmenopausal women, but I would say that premenopausal women often have more atypical presentations, such as nausea, jaw pain, shortness of breath. Women present on average later with their acute myocardial infarctions than men, and that's for a lot of reasons. One is women are the major caregivers in their house, so they may be too busy to take care of themselves. Also the lack of awareness. And as we all cardiologists know, time is myocardium. So the later you present with your acute coronary syndrome, the worse your outcome. Women, even in 2017, are less likely to receive aggressive medical therapy, including angioplasty, coronary artery bypass surgery, aspirin, statin, beta blockers. But hopefully that is improving over time. Women have more comorbidities, such as obesity, diabetes, and they have smaller hearts and smaller arteries. So we often see in the cath lab where women have small arteries and the arteries are too small to put a stent in, just because they have smaller arteries. Challenging for the challenges of evaluating obstructive coronary artery disease is that, again, the greater morbidities, the higher rates of false positive, and we often might limit the work, we might terminate the workup prematurely, and again, this atypical symptoms that I mentioned. So I just want to point out in terms of exercise stress testing that in women in particular, even though women have more women die of heart disease, they actually have less obstructive coronary disease. We have a lower QRS voltage, which might mean that the stress test is harder to interpret, meaning the 1 millimeter of ST segment deviation might be too high, and the effects of hormones. So endogenous estrogen can cause a digoxin-like effect on the EKG, and ischemia can actually vary during the menstrual cycle, and hormone replacement therapy actually promotes vasodilation, which causes a decrease in ischemia on imaging. So if you look at the American Heart Association statement on how to evaluate symptomatic women for obstructive coronary disease, it's if you have a normal rest EKG and you're able to exercise, you always start with exercise treadmill testing. And then based on that, you can either go to just medical management, and if it's intermediate, then go to the next category, which is stress cardiac imaging, which is reserved for people who cannot exercise, have an abnormal rest EKG, or potentially have diabetes. And then you treat accordingly. So if it's abnormal, then you may go on to cardiac catheterization. So that's what the American Heart Association recommends. If you look at the meta-analysis of different strategies on how to evaluate obstructive coronary artery disease in women, stress EKG actually has a lower sensitivity of only 61% in women, which is lower than in men, and 70% specificity. If you look at imaging modalities such as stress echo and stress nuclear, the specificity of stress echo is actually much higher at 76% because you get around this issue of breast attenuation. And for stress nuclear and stress echo, the sensitivity is about the same, over 80%. So I want to talk to you about a patient who really humbled me. I saw her a few weeks ago. So she's 62 years old, she's postmenopausal, and she just smoked in high school. She runs every single morning, she meets the same group of women, and they run 5 miles every morning for 20 years. And over the last few months, she can keep up with them, but she says, I kind of feel a little short of breath, I have a little bit of shoulder pain, but she still kind of runs with them. So appropriately, per the guidelines, her primary care doctor had a intermediate pretest probability for obstructive coronary disease. She's postmenopausal, has exercise-induced symptoms. And she went 9 minutes on the treadmill, had 1 millimeter of ST segment depression, so technically a positive test. And the next step was go on to nuclear imaging, which she did even more. She did 13 minutes, and I guarantee I could not do 13 minutes on the stress test. This is really, really good exercise capacity. This test was not really very positive for ST segment depression, and the images were completely normal. So what do you do next with her? And I tell you, this really humbled me because, if you go by guidelines, she's done, right? She had normal stress testing. But the two things that I'm glad I listened to was she told me something's wrong with me, and I listened to her. And two, she's an athlete, and often these tests are just terminated prematurely because they reach target heart rate. And she goes, the stress test didn't get me to my symptoms. It was easy for me. So I said, let's go on to the next step. So my pretest probability wasn't high enough to go right to cardiac catheterization. So I did do a cardiac CT on her, and then I got a page literally the hour after she had the CT scan telling me that it was very abnormal. So I had to admit her, and she went on to coronary angiography. And this doesn't need to move to show you that this is the catheter. This is her left main, and she's got a 99% narrowing of her left main artery. And this lady was running 5 miles a day with her friends for 20 years. So if we didn't detect this, she would have died. So this really humbled me, and I think what I learned from this is that if you have a woman with a reasonable story and she tells you something's wrong, women have good intuition, not that men don't, but you need to listen to her, and athletes can humble you as well. So my next story is a lady who's a nurse who has a history of hyperlipidemia. She has classic chest pain on exertion. She stops, it goes away. She's only on aspirin and atorvastatin. She did a stress test, and she did 7 minutes, so not as good as my athlete, but she did achieve target heart rate. She had ST segment depression, 1 millimeter, so positive, and the nuclear images show inferior ischemia. So I decided to go on to proceed to cardiac catheterization because she was bradycardic, and I didn't really have much room for medical therapy. So she went and had coronary angiography, and it was completely normal. So what is wrong with her? So I'm going to have you raise up your hands. So who thinks it's coronary vasospasm? Who think it's stress cardiomyopathy? Non-cardiac chest pain? And microvascular ischemia. All right, great. So the actual answer is microvascular ischemia. I actually think coronary vasospasm is overstated. I think in a lot of women who have chest pain, since we have no idea what's wrong with them, we tell them they have spasm. And I don't know that we have a lot of evidence in most cases that people...
And what does it mean?
And what does it mean? Exactly. Exactly. So women with chest pain and normal coronary arteries, I shudder to think of all the people I sent away in my training, these women with good stories, and I said, you're fine, there's nothing wrong with you. But women, as I mentioned, have a lower prevalence of obstructive coronary disease, but the leading killer of women needs to be explained. Yes?
How did you diagnose it?
I'm going to get to that. Up to 50% of women undergoing coronary angiography have normal arteries. And despite less epicardial obstruction, women present more often in the emergency room with chest pain, have more symptoms, and a worse prognosis. And we need to explain this paradox. So this is a slide I'd like to show to kind of explain it to you. So this is a coronary catheterization, left main, LAD, circumflex. And this is only 10% of our arterial tree. If you look at this Highland cast of the arterial tree, all this meshwork in here, you clearly can't see here, that's 90% of your vessels, so those are small vessels, which we cannot visualize on our current imaging techniques. Now you'll say, okay, so she's got chest pain, big deal, right? And she might have microvascular ischemia. But if you look at the WISE study, investigators that use stress MRI to evaluate for ischemia, they found that if you look at women who've got coronary disease down here, this is months to first event and freedom for events on the right axis, on the y-axis. If you look at women that have no coronary disease and normal MRI, so no ischemia, normal flow reserve, their freedom from events is up here. People with actually obstructive coronary disease is down here. And women that have no coronary disease but have abnormal myocardial resonance spectroscopy, so evidence of diminished coronary flow reserve, their mortality is almost just as bad as women with coronary disease. So it's not a benign prognosis. Again, if you look at the Women Take Heart study, which is about 1,000 women who are completely healthy, and you can compare them to the WISE population, which are women that have normal coronary arteries or CAD. 2.4% of the women who are asymptomatic had composite endpoints. If you look at compared to women with coronary disease, it was 16%, but if you have normal coronary arteries but chest pain, it was about 8% of a composite endpoint. So this is not a benign diagnosis. But again, it's a really hard diagnosis to make. It's often questions. You cannot visualize it by coronary angiography. I have my next slide shows that you can do intracoronary, nitroglycerin acetylcholine to look at coronary flow reserve. We just don't really do that anymore. It's not really very feasible. And as if the abnormality may not be in all vessels and it might be a few patchy vessels here and there, you might actually not be able to see it. It might be below the detection techniques of SPECT imaging, for example. And it can be intermittent in nature. So the diagnosis, what we do at Mass General is we usually send women for PET imaging to look at coronary flow reserve, or you can do stress cardiac MR, which we actually are not, our MR lab is not up to snuff yet to do it, so we send people for PET imaging. We don't really use the coronary reactivity testing. But to be honest, if I have a woman who's got normal coronaries, a really good story, I often don't do any testing. I treat her as on SPECT for this. And this nurse that I have, I put her on, she's already on aspirin and statin, I put her on a calcium channel blocker and her symptoms went away and she feels great. So to me, so her story, everything just fit together. I didn't feel like I needed the test to make the diagnosis because I already had it on a clinical basis. So treatment goals are to reduce angina, improve quality of life, but in the current angina guidelines, they don't talk about microvascular disease at all. There is a high prevalence of atherosclerosis, so small vessels, kind of non-obstructive, so we often recommend aspirin and statins, and there's no absolute randomized controlled trial data at all that shows anything that shows reduction of major adverse cardiovascular events. Okay, my next case is a 35-year-old who's seen for preconception counseling. 2 years previously, she was admitted with an acute coronary syndrome and had the following cath findings. So I don't know if you can see that, but I'll tell you that there's an abnormality here, maybe down here. So this lady had multivessel coronary artery dissection. So she's asking me if she should get pregnant again. She feels great right now. So she's currently symptom-free. She's on aspirin and beta blocker, excellent exercise capacity, and we did a stress test and she had no ischemia. So what do you recommend? Continue aspirin, beta blocker, and she can go ahead and get pregnant? Who says that? B is do not recommend pregnancy. And C, continue aspirin, hold the beta blocker because the risk of IUGR in the fetus, and proceed with pregnancy. Okay, so probably the right answer is do not recommend pregnancy, which I'll talk to you in a minute about. So Sharon Hayes in Mayo Clinic put out one of the landmark article looking at coronary artery dissection in 2012 in Circulation, and they was one of the biggest cohorts at the time, though this summer the Vancouver group came out with a bigger cohort of about 300 patients, but this is the original largest cohort, and it looked at 87 patients. The mean age was 42, so these are young women, and most of them are women. 20% of the women were postpartum, meaning they were in their last trimester or just had a baby, at a mean of 38 days postpartum. One thing they did find is that often these women have fibromuscular dysplasia in other territories, so head and neck, abdomen and pelvis. So we pan-CT head and neck, abdomen and pelvis, and in the Jackie Saw British Columbia cohort, they had about 60% of women also had associated fibromuscular dysplasia. The median follow-up in this study was 47 months, and 17% of the recurrence, all women, and the 10-year mortality was almost 10%. So this, again, is not a benign diagnosis. So the etiology could be the result of an intimal rupture with subsequent disruption of the vessel wall, or maybe it's bleeding of the vasa vasorum, which results in an intramural hematoma. No matter what, it's like a progressive pressure-driven phenomenon with enlargement of the false lumen and subsequent compression of the true lumen, causing ischemia or infarction. So I would just say that you have a heightened suspicion in young women. There's plenty of situations where you see a young woman with chest pain who doesn't have an EKG, doesn't have troponins drawn. And I think we just need to have a heightened troponin, a heightened suspicion. You can do an EKG, obviously, troponin, bedside echo to look for wall motion abnormalities. And in this situation, less is more. So proceeding to coronary angiography is not always the best intervene on these vessels, you can actually propagate the dissection just because they're friable and you can actually make things worse. So what we often recommend is if you have someone who's stable, not having an acute ST segment elevation MI, not in cardiogenic shock, you might do a cardiac CT first and not take them to the cath lab first. But if you're in shock, if you're unstable, if you're having ST segment elevation, you do need to go to the cath lab. And there's definitely the situation where you can have iatrogenic propagation of the dissection, and PCI in these situations actually often don't work very well, and often these dissections improve over time anyway, so you actually don't need to intervene. You might want to consider subselective shots, especially in peripartum patients. And if you're not sure of the diagnosis, you can use intravascular ultrasound or optimal coherence tomography. And those are the situations where a lot of women can come in with chest pain, their troponins are positive, they go to cath and they see nothing. I would say in a lot of the situations, you probably have a small dissection that you're missing. And this is a really nice review article from the Mayo Clinic folks, again, looking at the general management of SCAD. And for the outpatient management, they recommend avoiding pregnancy. So I think in North America in 2017, if you've had a previous dissection, you would not recommend another pregnancy because pregnancy itself causes changes in the histology of your vascular system, so you can have it more likely to have it happen again. Saying that, at Mass General, we just had a woman who just had a pregnancy and delivered about a month ago with SCAD. And I think in Europe, they're a little less, they're less strict about it, but I think for the safety of the women, we'd recommend not getting pregnant again, and we still need more data to figure out exactly how to counsel these women, because it's a really difficult time, because these are women who are young, and to tell them they can't get pregnant again, it's really, really difficult, and these are the situations where we have women crying in our office, because it's a major life-changing issue. And this is one of the patients we had who had coronary artery dissection, who we didn't know, she had an acute LAD, and we didn't know why. And this is optimal coherence tomography. This is the catheter. This is her left anterior descending artery. And this is the intima here. And you can see the break in the intima, and then this big intramural hematoma around it. So I want to talk about pregnancy because one statistic I'm still having trouble coping with is that, I don't know if you guys knew that maternal death in the United States is highest than any other developed country in the world. So our maternal death is 26 women die per 100,000 live births. And if you look at similar countries like Canada, Australia, it's 4. So we're 5 to 6 times higher than other developed countries. So I think it behooves us to, especially cardiologists, to understand what happens during pregnancy to a woman's heart. And I can tell you that when I was in training, I got absolutely no formal training on how to deal with pregnancy, but our fellows and are going to go out into the real world are going to definitely be asked to manage these women without any formal training. So we're also seeing more women who are older as they get pregnant, so they're more likely to have pre-existing conditions. There's more women who are having twins, triplets, and quadruplets. So when all the hemodynamic changes I'm going to talk about are more likely to happen if you're having multifetal pregnancies. There's more women who are obese and diabetic, increasing the risk of cardiovascular complications. And then the patients with congenital heart disease who were previously had already died or were too sick to get pregnant are now fertile and able to have pregnancies. And also childhood cancer survivors who may have died are now surviving and planning families, but now they've also had cardiotoxic therapy such as chemo and radiation. So this is causes of pregnancy-related death, and if you look at, this is CDC data up to 2012, non-cardiovascular disease is here 15%, cardiovascular disease is also 15%, but for some reason they exclude cardiomyopathy, so add that onto this, thrombotic pulmonary embolism, hypertensive disorders of pregnancies, and strokes. So if you add all those up, cardiovascular disease is the leading non-obstetric cause of death in these women. Now, when you're pregnant, unlike everything else in cardiology, we don't have randomized controlled trials of thousands of patients. We really don't have that, so really we need to understand what happens when someone's pregnant. So one of the first things that happens is plasma volume goes up, and that's because of increase in renin and reduced atrial natriuretic peptide. And this all happens as early as the first trimester and peaks to about 30 to 50%. As a result of plasma volume going up and heart rate going up, stroke volume goes up as well. The initial rise in stroke volume is due to increase in plasma volume, and then after that it's due to increase in heart rate. RBC mass goes up due to increased EPO levels, but it goes up less than plasma volume, so you actually have a dilutional anemia of pregnancy, which is actually beneficial. So if you don't have that dilutional anemia, there's an increased risk of miscarriage, and we think that anemia actually protects, it reduces blood viscosity, so it actually helps uteroplacental flow. And hematocrit falls. Now, systemic vascular resistance also falls, and it falls up to 25-30%. And again, all of these changes happen very early in pregnancy and persist till delivery. And blood pressure falls as a result, though it comes closer to normal at term. Now, often these women in the past, when they were treated at our hospital, we'd get them through pregnancy and we'd get them to the labor and delivery room and we'd all be celebrating, hey, we got them here. But actually, labor and delivery is one of the highest risk times. So some poor women in the 1980s allowed someone to put Swan-Ganz and central venous catheters in them, and they saw what happened during labor and delivery. So every time your uterine pressure went up, your CVP went up and your wedge went up. So you can imagine if you have a pre-existing cardiovascular condition, this could be a higher risk time. And all of these changes resolve within weeks to months post-delivery. But the highest risk time is probably the first few days after delivery, because what happens is the placenta is one of the reasons why your systemic vascular resistance falls. So suddenly you deliver, your placenta goes away and your SVR goes up suddenly. And then your preload suddenly goes up because you get uteroplacental transfusion of this blood and then remobilization of dependent edema. So right after you deliver, you're increasing your preload and you're increasing your afterload. So for many cardiac conditions, this is actually not beneficial. So again, on the same theme, I saw a 28-year-old lady who presented 16 weeks pregnant, and she had a murmur by obstetrician. She was born in India, but emigrated to the US at the age of 12, and she had no prior cardiac history. She had no symptoms whatsoever. So which valve lesion would be the least concerning for maternal and fetal risk during her pregnancy? Aortic stenosis, moderate; mitral stenosis, moderate; and mitral regurgitation, severe. So who says A? So the least concerning. Who says B? And who says C? Okay, so the correct answer is C, and I'll tell you why. So from the Toronto group, they came up with a classification system to try to help risk stratify women who are pregnant to determine their risk of cardiovascular events. And I know that a lot of people in this room aren't cardiologists, but I think it would be better for these women to be risk stratified before they came to me pregnant, and to be seen in your offices to say, hey, I don't know that this woman should get pregnant. And the reason I say that is our fellows who went into cardiology for a reason never think about their young women getting pregnant. But the reason we started our pregnancy program is we had this young woman who's 40 who had an acute MI with an RCA stent. A few months later, she had more symptoms, then had an LAD stent with a VF arrest, etc. No one talked to her about, hey, maybe she could get pregnant. She's only 40. The next thing she comes in, she's 12 weeks pregnant. So no one talked to her about that. She's on an ACE inhibitor, she's on statin, she's on a beta blocker, and she has aspirin and Plavix, and she's pregnant. So I think it's better for them to show up with you guys than to show up with me pregnant, because then it makes it much more difficult. So this is why the scoring system is important. So they came up with a scoring system, and basically each one of these points each gets a point. So if you had a history of a prior cardiac arrhythmia or event, you get 1 point. If your NYHA status is 2 or more, or if you're cyanotic, you get 1 point. Left heart obstruction, so a mitral valve area of less than 2, so that's not severe mitral stenosis, that's only mild to moderate mitral stenosis. Aortic valve area of less than 1.5, so again, that's not severe aortic stenosis. Or left ventricular outflow tract obstruction over 30 millimeters of mercury. And if your EF was less than 40, that got you another point. So if you had 0 points, you had a 5% risk of an adverse cardiac event during pregnancy. 1 point gets you 27%, and 2 points or more gets you 75% risk of a bad thing happening to you when you're pregnant. Valvular regurgitation is generally well tolerated during pregnancy. So because of the fall in the systemic vascular resistance, it's like giving someone an ACE inhibitor. It actually is really well tolerated during pregnancy. So if I see someone with severe mitral aortic regurgitation and they're asymptomatic and their LV function's normal and their LV is not dilated, I can tell them, go ahead and get pregnant. Now's the time to do it, because having a bioprosthetic or a mechanical valve during pregnancy is actually a whole other problem that we have to deal with. But if you have someone with mitral stenosis, even moderate, or aortic stenosis, even moderate, these women need to be counseled before they get pregnant. The WHO came up with a more comprehensive classification scheme, and they basically came up with 4 categories. Category 1, very little chance of morbidity or mortality, so uncomplicated pulmonary stenosis, PDA, mitral valve prolapse. WHO 2, again, these women don't die, so even if you have an ASD that's unoperated, RV function's normal, you're fine. Repair tetralogy, most arrhythmias. When you start getting into the 3 category, you start getting increased morbidity and mortality, so hypertrophic cardiomyopathy, Marfan's with normal aortic roots, mild LV systolic dysfunction. The 3s are the women that are at much higher risk of morbidity and mortality, so mechanical valves, complex congenital heart disease, aortas over 40 in Marfan's or above 45 in bicuspids. And the 4s are the women that we would really recommend they don't get pregnant at all. So pulmonary hypertension, EF less than 30, NYHA 3 or 4, previous pericardium with residual impairment, severe MS, severe AS, Marfan's with big aortas, bicuspid with big aortas, and severe coarctation. And I'll tell you that these Marfan and bicuspid numbers are really not based on any good data. It's just a group of people going into a room and deciding that that's the number. In Canada and Europe, Marfan's, their number, actually this number is 40 in the US and it's 45 in Canada and the US. And the 50 number for bicuspid was just taken out of the air. Even in your best situations, when you tell a lady that we don't recommend she get pregnant, it's a very personal decision getting pregnant between a woman and her partner, and there are certainly women that show up pregnant despite all of our best recommendations. So mode of delivery is, we never tell our, very rarely do we tell our obstetricians that they need to deliver a woman by C-section. I think that's one of the biggest misnomers out there. Vaginal delivery is much safer because there's less blood loss, less risk of infection, thromboembolic complications. And really we just have them have a C-section for obstetrical indications. There's no consensus on when me as a cardiologist would recommend a C-section, but it could be if someone has an acute dissection because you don't want them to push. Anticoagulation and preterm labor because warfarin passes across the placenta, so you don't want the baby to be anticoagulated and have their head go through the birthing canal. Marfan's with a big aorta because you're worrying about, again, Valsalva and pushing and increasing the risk of dissection, or someone in intractable heart failure, so the mother's just really unstable, you just want to get the baby out. Another thing we've been doing more is considering an assisted second stage, so that just means that you let the women get to the point of labor where everything's dilated, and instead of her pushing, you use forceps or suction to get the baby out so that there's no Valsalva or pushing involved. Okay, so this is a lady that actually showed up to my clinic a few months ago, and she's 32. She had no prior cardiac history. She presents 38 weeks pregnant with palpitations. Her heart rate was 200, but she looked really good just lying there. In fact, my medical assistant didn't even tell me about this EKG. She's like, next patient's ready. I walk in, and this is her EKG. Blood pressure is 110/70, and this is her EKG, which shows a very rapid, narrow, complex tachycardia, so supraventricular tachycardia. So what would you do? Cardioversion A, so who would do that? 2, vagal maneuvers and or IV adenosine. C, IV amiodarone. And D is urgent C-section, then management of the arrhythmia per guidelines. So who wants A? B, C, and D. Okay, so she's completely stable, so we don't, and the baby's fine, so we don't actually have to do an urgent C-section. IV amiodarone we don't use in pregnancy unless you're in an ACLS type of protocol because of the effect on the fetal thyroid. We don't have to cardioverse, she's completely stable, so what we did with her is we did vagal maneuvers, which didn't work, so then we gave her IV adenosine and she converted. So probably one of the most common reasons I see someone in my pregnancy clinic is arrhythmias, and it's such a very common complication. And these women aren't crazy. There's a real reason why they have palpitations. So one is they're just feeling that increased blood volume. Your blood volume goes up 50%. But also, your heart stretches when you're pregnant, so it means everything's more irritable. So you're more likely to get arrhythmias. And you have increased adrenergic responsiveness and a higher resting heart rate. So in pregnancy, you see women that may never have had an arrhythmia that suddenly develop an arrhythmia when they're pregnant. But most of them are benign. Premature beats and sustained tachyarrhythmias become more frequent or manifest for the first time in pregnancy. We have very little data on the use of antiarrhythmic drugs during pregnancy, and if you're someone who's already on an antiarrhythmic, whether to continue them or not is kind of a very individualized decision. You can certainly ablate someone during pregnancy, but you want to wait to the second trimester because you want to avoid radiation exposure during organogenesis. And during the third trimester, the heart is kind of shifted up and in weird ways, so it's harder for the EP guys to get into the right position. And if you have an ICD or pacemaker, there's no contraindication. You can absolutely get pregnant. Okay, and hopefully none of you will have to manage a cardiac arrest during pregnancy, but there's a beautiful circulation document that came out a few years ago that is really a good read, but the key points from this are use the ACLS protocol. So you can use the amiodarone, epi, everything you need to do. But one thing you have to remember is when someone's pregnant, if you have them supine, you can actually lower cardiac output by 25% just by the baby pressing on the inferior vena cava, and you'll also get increased afterload or outflow tract compression from the aortic compression. So in past guidelines, they would say that tilt the woman to the side, but the newer guidelines actually say one person from the team has to lift the uterus up and push them to the left. So that's, you have the woman flat, because that's the best way to administer ACLS, but you have to lift that uterus off the IVC. You have to deliver the fetus within 4 minutes, so this is not transferring the woman to the OR and doing cleaning and cutting. This is like dirty work. You just go in there and cut and get the baby out. You have to consider magnesium toxicity if someone's on it because of preeclampsia. And unfortunately, maternal hypoxia occurs earlier than a non-pregnant woman, so a woman's functional residual capacity is lower because you can't expand your lungs as much. The oxygen hemoglobin dissociation curve is shifted to the right, so it's easier for a woman to get hypoxic when she loses her oxygen. The fetus, on the other hand, shifts to the other side, so the fetus is protected. It's a perfect parasite. Okay, so I talk about all these fancy things, but many of you may not see this, hopefully, but what you will see is a woman during a pregnancy who developed gestational diabetes, preeclampsia, or pregnancy-induced hypertension. In fact, when I was on my Uber ride here from the airport, the woman was telling me that her daughter has pregnancy-induced hypertension. I didn't want to tell her that I knew all about this. I just listened. but this is a problem, and we don't know if it's you had a pregnancy and you always were at risk, so now you failed the stress test, and this just means that when you're older, you're more likely to get heart disease, or if preeclampsia causes endothelial dysfunction that just propagates over time. And this is not just little small risk. If you look at over time with the people in red are the people that did not have preeclampsia and had a term delivery, and this is survival. And then you look at those people who had preeclampsia and preterm delivery, which is less than 34 weeks, their survival is much lower. And these aren't women in their 70s and 80s, these are women in their 50s. So these are younger women that are having cardiovascular events. And what to do with this, I honestly don't have a clue what to do with it, other than to tell women, you had preeclampsia or gestational diabetes, so you are at increased risk of cardiovascular events, not when you're 80, but in the next 5 to 10 years. And also it's a time when women, though, are the least likely to take care of themselves. So it's a really hard time to tell someone, now you got to exercise every day and eat healthy. It's a really tough problem, but hopefully over time we'll know better how to manage these women. So in conclusion, cardiovascular disease is the leading cause of death in women. We need to understand that a woman's heart is different, and thank goodness for conferences that now are including heart disease in women as part of their discussions. When you see a pregnant woman, so for all of you, if you have any woman that has any type of heart disease who wants to get pregnant, discuss if that's a safe thing to do. And all diseases are not created equal, so evaluation of maternal risk is key. So thank you very much. Yes.
Are there questions? Scott?
I'll start right here.
Previously, you had mentioned cardiovascular CT.
Yes.
Are you talking about coronary artery calcium scoring?
No, we don't really do calcium scoring. We just go straight to the coronary CT because now the technologies are so good that the radiation exposure is so low. So we get at MGH we get 1 to 3 millisieverts, which is the same as living at sea level for 1 year, and so we just go straight to. We don't do calcium scoring. We just go straight to full cardiac.
So what are you looking for?
Depends on what so for that lady, I just didn't feel good enough about excluding coronary disease in her. So for her, I was looking for coronary disease, like obstructive coronary disease.
Obstructive coronary disease?
Using the same technology in the ER.
Yes.
I thought you were talking about
evaluation of chest pain in the ER, and the coronary CT is part of their,
Pretty much it's routine in the right person.
Yep, in the right person, exactly.
what I'm asking.
Exactly. Yep.
Maybe he can say.
Do you want to try and? I think
Not quite understanding your coronary CT. You're looking for obstructive coronary disease. You're doing a CT cath?
No, just a CT scan, not a cath.
It's like CT angiography.
Yeah.
You're doing CT angiography.
Yes.
Oh, we don't have
contrast.
we don't have that capability.
Oh, okay.
It's pretty routine now.
And I think it's a really good, the people to use it for are people that have, like with her, who had an intermediate pretest probability, not high enough that you go straight to cath, but you just don't feel right about excluding it completely. Yeah.
I have two questions, so I
Sure.
apologize to everyone else waiting to ask you questions. But the first part is you talked about maternal mortality compared to other developed
Yep.
countries, and then you talked about the cardiovascular burden. What is the hypothesis that increases that burden in our country as compared to other countries, or is there another reason outside of the cardiovascular
Yeah, that's a
burden?
really good question. I think one of the things I was reading was, I guess, maternal fetal medicine may not be as, you don't actually need to have some formal education in some areas to be a maternal fetal medicine specialist. I think one is awareness, and I think one is there's certain pockets of the country that are just more obese, more diabetics, who are just not getting good medical care. I think that's part of the problem. Yeah.
And then my second question, unrelated, but there was just the JAMA article that came out on the fat attenuation index and looking at cardiovascular risk stratification. I didn't know if you had any comments on that. I know that's not really specific to women's heart disease, but just wanted to hear your thoughts on that.
Tell me about that again.
It was a JAMA article that was looking at fat attenuation indexes
Okay.
using CT scans to look at perivascular inflammation as a predictor of later on developing coronary artery disease outside and independent of obstruction, CAD.
Okay, yeah, I don't have any comments
Okay.
on that in the women's population. So.
Probably done in men.
Yeah.
The study was probably done on.
So quick question. So excellent talk.
Thank you.
Now I'm wondering, so when you mentioned that there are some conditions where women, you tell women you can't have a pregnancy or another pregnancy. So I started thinking, so what about women who then want to go through in vitro fertilization and all those other things? Are those treatments going to cause cardiac side effects
That's
as well?
a really good question. That's so there. I think that's an emerging field. It's a really good question. So I think there's some data that women who are infertile in general have an increased risk of cardiovascular events. And I just had a lady who had a dissection postpartum who wants to get pregnant again, and she's like, "Can I do egg retrieval and then surrogate?" And I don't know the answer to that. We don't know the answer to that. But that's like I think across the country people are looking into that.
So, because the reason why I say that, because I know that, through my medical school training and having different clinics I rotated, there is this hyper-ovarian
Stimulation.
and
Yep.
then you have renal disease, and you have all these side effects.
Yep.
So, I don't know if those women would then even have that option. So I was just curious.
Yeah, no, and I think for like the dissection population, I think that the hormonal effects are probably not beneficial for the surge that they give you, but for other conditions, I think it's very individual, and I think the fertility docs are still trying to figure out, because they're going to see more and more people who are just sicker, wanting to get pregnant. Yeah, yeah.
As an internal medicine resident, I did a month of OB, actually 6 weeks, because of how many sick people there were there.
Yeah.
Everything from rheumatic heart disease to bacterial endocarditis to heroin withdrawal, you name it. It was like an ICU, only they were pregnant, adding to the issue. There's an excellent book written, at that time it was by Guttmacher and Ravinsky, but it's called the Mount Sinai Group. And for people who, because most doctors that do medicine don't want to fool with pregnant ladies. It's like they're radioactive. Yes. But anyway, I was one of the few guys that would do that. And this book is now put out by the Mount Sinai Group, called The Medical, Surgical, and Gynecologic Complications of Pregnancy. Yep. And man, is it a winner. It really went through a lot of things. Everything from gastric achlorhydria, why we never see ulcers in pregnancy, to the 80% volume load of the vascular capacity that goes on in pregnancy. Yeah. But it's a great book for people who are going to do that, and unfortunately we don't cross-train very much.
That's exactly right.
But in Indiana, since we had a few doctors, we needed to cross-train because these people have significant medical illnesses, and actually it was a lot more exciting than being on a medicine ward half the time.
So at MGH, we were, like I said, our fellows, who are really smart Harvard fellows, they don't get any pregnancy training at all. So we created a course where we have maternal fetal medicine fellows, OB, anesthesia, and cardiology all in one day in September on Saturday, and we talk about all these conditions. And so hopefully with courses like that, people will become better educated.
Well, the other problem is that nobody is allowed to study any medicines in pregnant ladies. You
Right.
know, if you look at any, whether it's antibiotics or antiarrhythmic drugs, they've never been studied in
Right.
pregnancy because of the possibility of fetal harm and,
Right.
and malpractice. And I don't know how we're ever going to resolve that, but it's really a no man's or woman's land.
Yeah.
Got to be politically
So
correct these
in our
days.
center, they're certainly,
Congratulations.
Yes, to do these things.
we have a lot of my, a lot of my colleagues don't want to manage these patients, so they often send them to our group to manage. So like they're like, thank you, take them while they're pregnant, and then I hand them back once they're not pregnant anymore. Because most people, they're too scared to handle it, so, yeah.
Can I ask like a four-part question?
Sure.
Number one,
Either my talk is really terrible.
patients to you? I'll be fast. Do you take patients from out of state? Okay, so as far as hypertensive disorders,
Yep.
the pre-existing chronic hypertensives,
Yep.
the gestational hypertensives, the preeclamptics and eclamptics, the
Yep.
postpartum suddenly, where did this come from,
Right.
hypertensives, and then long-term, what do I do for you?
Right.
Okay, so what are your meds of choice for gestational or
Yep.
pre-existing?
So one thing is, so if you have a woman who's a fertility age, I think generally the MFM groups say no ACE inhibitors or ARBs. So in pregnancy, we often use labetalol. I think methyl-dopa is on that list, though I haven't really actually used it. We use metoprolol and nifedipine.
Okay, and so how long do you normally expect to keep that going postpartum? And
So-
how do you taper? How fast do you start tapering?
I think it depends on, so they have, usually they're seen by OB within 1 or 2 weeks of discharge, and then starting to taper then, depending on how severe their blood
So we can
pressure
just
is.
use our judgment and things?
Exactly,
Okay.
there's no set guidelines on how to do it.
Okay, so considering their risk in the future.
Yep.
Say I taper them down, do I transfer them to adult medicine or cardiology at their 6-week checkup? Do I
Yep.
say 6 months from now? How often?
That's a really good question. So there are clinics sprouting up across the world where women like this are sent to a one-time clinic to assess their cardiovascular risk, which we're hoping to start up. I know they do that a lot in Canada.
And if in a public health setting you don't
I
have
know.
that luxury,
I think what you
they
need to
come back
do
me?
is make sure that the primary care doctor knows that they're at risk, and make sure that when they're not breastfeeding, they check them for diabetes and lipids and make sure they monitor the blood
So
pressure.
maybe 6 months, within 6 months
Yep,
of delivery, you think
exactly.
it'd be reasonable? Okay, thank you. That was a wonderful talk.
Thank you.